You go out to a nice restaurant, you sit down, and they hand you a menu.
Right.
And right next to the steak, there's a price.
Mm.
Right next to the glass of wine, there's a price. You order, you enjoy your meal, and when the bill actually arrives...
It matches the menu.
Exactly, it matches the menu. Or think about buying a car. I mean, it is a massive, highly consequential purchase. Right?
Oh, yeah. Usually the second biggest purchase of your life.
Right. So you walk onto the lot, you test drive a few models, and then you sit in that, tiny little office with a salesperson, and you negotiate a bottom line.
You know exactly what you're getting into.
You sign the paperwork, knowing the exact dollar amount that will be leaving your bank account.
Mm-hmm.
The way we handle money in, almost every aspect of our lives is based on visibility. We evaluate the cost, we evaluate the value, and then we just make a decision.
Because it's the basic foundation of how humans exchange goods and services.
Right.
The buyer just, they have to know the price before the transaction occurs.
But then you step into the world of healthcare in the United States. And it's honestly as if you have walked through a portal into an alternate universe where the fundamental laws of math and commerce they no longer apply.
They completely vanish.
They vanish.
Yeah.
You break your arm, or you have a baby, or God forbid you get a scary diagnosis, you receive the treatment, and you have absolutely no idea what any of it costs.
Nothing. Total darkness.
You are essentially forced to sign a blank check, hand it over to this incredibly complex bureaucracy, and then you just wait. You wait months for a completely incomprehensible piece of paper to arrive in the mail, essentially telling you what you owe.
It's terrifying, honestly.
It is. So let me ask you, the listener, right now, have you ever been hit by one of those surprise medical bills that just, derailed your finances for months? Or maybe you felt entirely paralyzed because you knew you had this massive high deductible, so you avoided going to the doctor altogether.
Which is the daily reality for millions of Americans. I mean, you are making some of the most high-stakes decisions of your entire life.
Literally life or death sometimes.
Right. Decisions about your physical survival and your financial solvency, and you're making them while basically wearing a blindfold.
Untangling that incredibly frustrating labyrinth is our mission today. We are doing a deep dive into a stack of sources, but we are primarily grounding this entire conversation in a deeply researched, remarkably detailed piece of writing from a blog called Barrack Face.
Yeah, it's a fascinating post.
It really is. It's dated Saturday, June 13th, 2026. The author, who actually mentions being a very early full-time volunteer for Barack Obama in New York City, has essentially drafted this comprehensive manifesto on the U.S. healthcare system.
A total teardown of the mechanic.
Exactly. And we are going to explore a really fascinating policy progression that's outlined in this text. We're going to look at how aggressive, market-driven transparency reforms, specifically solutions that have been championed by billionaire Mark Cuban.
Right. His recent stuff.
Yeah, how those could theoretically serve as the architectural bridge to a full, progressive, single-payer healthcare system.
Which sounds completely contradictory at first glance.
It does, but the way it's laid out is incredible. But before we start dismantling the engine of this $4 trillion industry, I want you to just establish the framing for our discussion today.
Yeah, that's crucial. We really need to be clear here. The source material we are unpacking today touches on deeply polarizing, incredibly politically charged concepts.
Very charged.
Right. We will be analyzing right-leaning, free market capitalist solutions that rely heavily on deregulation and intense competition. And on the flip side, we will be analyzing left-leaning, government-run universal healthcare models that rely on massive public funding and federal oversight.
The whole spectrum.
The entire spectrum. So our role today is strictly analytical. We are not taking sides, we are not endorsing a free market utopia, and we are not condemning or advocating for a government takeover.
We're just looking at the blueprints.
Exactly. Our sole purpose is to impartially break down the mechanical architecture, the economic friction, and the specific, very brutal trade-offs of both approaches. That way, you, the listener, can fully understand both sides of the debate on their actual merits, rather than just, political talking points.
Perfect. So we have to start with the diagnosis. I mean, before we talk about the cure, we really have to look at the disease currently infecting the system.
Which brings us to Mark Cuban.
Right. The source frames this entire discussion around comments made by Mark Cuban in a tweet back in June of 2026. He was talking about the tension between capitalism and socialism.
Yeah, and he makes a really interesting distinction there.
He does. He points out that the mechanism creating vast wealth for everyday people is actually the stock market. I think the source cites upwards of 150 million Americans participating in it, whether directly or, through their retirement accounts.
Like a 401k or an IRA.
Exactly. But when he pivots to look at the dysfunction, the massively inflated costs, and just the sheer misery of the U.S. healthcare system, he argues that the core villain isn't the broad concept of capitalism itself.
No, the author highlights Cuban's view that healthcare delivery at its most basic fundamental level is actually quite simple.
Right. A patient needs care, a physician provides it.
Exactly. But the current system has been heavily financialized and artificially obfuscated by what the text refers to as behemoth healthcare conglomerates.
Behemoth conglomerates.
Right. The illness isn't that doctors are trying to make a living or that hospitals need to keep the lights on. The illness, according to the source, is a deliberate, highly engineered opacity.
And the main mechanism driving that opacity, the thing creating the darkness, is vertical integration.
Yes, a big one.
I really want to spend some time on this because you hear vertical integration and it sounds like this dry, boring business jargon.
That sounds like an MBA textbook.
Exactly. But it is actually the direct root cause of why your routine blood test can somehow cost $500.
Let's unpack it.
So in a healthy, normal market, you have different independent companies performing different roles, right? And they compete against each other. But in our healthcare system, vertical integration means a single, massive corporate umbrella essentially owns everything.
They own the entire pipeline from end to end.
Right. They own the health insurance company that collects your monthly premiums. They also own the pharmacy benefit manager, the PBM, which negotiates the drug prices.
And they own the retail pharmacy where you actually go to pick up the pills.
Sometimes they even own the local physician practice networks.
It's all under one roof. And the economic consequence of owning that entire pipeline is massive information asymmetry.
Which means someone knows everything and someone else knows nothing.
Exactly. Let's say I am an employer, right? And I provide health benefits to my employees. I am funding a massive portion of the U.S. healthcare system.
Employers foot a huge chunk of the bill.
They do. Yet, as the employer, I don't actually know the true cost of the care I am financing. I hand millions of dollars in premiums over to the insurance arm of the conglomerate, but I am legally blocked from seeing what that insurance arm is paying the pharmacy arm.
Or what rebates the PBM arm is secretly pocketing from the drug manufacturers.
Right. The money just swirls around inside the corporation and you never see the actual receipts.
Which brings us directly to the pharmacy benefit managers, the PBMs. I mean, the source goes after these entities relentlessly. And honestly, reading through it, to me, a PBM operates exactly like a corrupt bouncer at a wildly popular nightclub.
Oh, that's a perfect way to look at it. Let's follow that analogy. The PBM is the bouncer standing at the door holding the VIP list.
Right, and in this case, the VIP list is the drug formulary.
Yes.
The PBM dictates which medications are allowed to be covered by your insurance and which ones are kept out in the cold. But the corruption doesn't stop at the door.
Not at all.
This bouncer is secretly shaking down the DJ, charging them for the right to play music. They are taking a silent 20% cut from every single drink the bartender pours.
And crucially, they force everyone in the club, the DJ, the bartender, the patrons, to sign strict non-disclosure agreements.
Gag clauses.
Exactly. No one is legally allowed to compare notes on what they paid to get inside or what the drinks actually cost to make.
It's unbelievable. You have this shadow entity extracting tolls at literally every possible choke point. The text describes this as spread pricing and hidden fees.
Spread pricing is where the math really gets wild.
Explain how that works.
So the PBM might negotiate a drug price with a local pharmacy for, say, $10. Then they turn around and bill the employer's health plan $50 for that exact same drug.
Wait, they just inflate the bill by $40?
Yep. And they simply pocket the $40 spread. It's essentially a localized monopoly operating entirely in the dark.
And we see the downstream effects of this clearly in how these entities treat, like independent pharmacies, the mom-and-pop places.
Oh, they squeeze them mercilessly. The source notes that because PBMs dominate the market so thoroughly, they use extortionate practices to just crush any competition.
Like what?
Well, they conduct these aggressive post-payment audits. They'll essentially claw back money from an independent pharmacy months after a prescription was already filled and paid for.
Just take the money back.
Yeah, and they charge independent pharmacies exorbitant fees just to transmit claims through the PBM's proprietary software hubs. They intentionally delay reimbursements to starve the smaller competitors of cash flow.
So they just bleed them dry.
Exactly. Cuban himself is actually quoted in the source saying there is, quote, no competition except to be on the PBM formulary.
Which completely short-circuits the fundamental promise of a free market. I mean, the theoretical defense of American capitalism is that bad actors and bloated middlemen, well, they eventually get disciplined by competition.
Because consumers just leave.
Right. Consumers realize they're being gouged, and they take their business elsewhere. But these vertically integrated conglomerates face absolutely zero competitive pressure.
How could they? The consumer, meaning the patient, has no leverage and absolutely no visibility into the pricing.
None at all.
And this brings up an incredibly vital point the text raises about something called deductible yield.
Oh, yeah. Let's define that, because it really gets to the heart of how the doctors and hospitals are also trapped in this mess.
So deductible yield refers to the actual percentage of a patient's high deductible that a hospital or a doctor successfully manages to collect.
Because the deductibles have gotten so huge.
Exactly. In our current system, insurance companies have shifted more and more of the initial cost burden directly onto patients. So a patient might owe the first $5,000 of their care out of pocket.
Which is a ton of money.
Right. The problem is many patients simply do not have $5,000 sitting in a checking account. So they go to the hospital, they receive care, the hospital bills them for that $5,000 deductible, and the patient defaults. They just can't pay it.
So the hospital ends up writing it off as bad debt.
Exactly. So the hospital's yield on that deductible is incredibly low. They are providing the labor, the expertise, the materials, but the money just never arrives.
And because the hospitals are bleeding money from all these uncollected deductibles, plus the massive administrative overhead required just to fight with the insurance conglomerates.
They respond by artificially inflating their charge master prices.
The sticker price.
Right, the sticker price of the procedures. It creates this vicious upward spiral. And then think about what happens when a patient finally does hit their out-of-pocket maximum for the year.
Oh, this is the craziest part. They stop caring entirely about the cost.
Completely.
I mean, if I've hit my deductible in, say, August, and my insurance is now covering 100% of whatever happens next, I have absolutely zero incentive to shop around for a cheaper MRI or, like, a more cost-effective physical therapist.
Why would you? Doesn't cost you anything at that point.
Right. It's not my money anymore.
And that is the exact perverse incentive structure the source describes. The patients lack any data to shop for care when they are paying out of pocket, and they lack any incentive to shop for care once the insurance kicks in.
It's broken on both ends.
The text contrasts this modern nightmare with a hypothetical 1955 era.
Ah, the golden age.
Well, structurally at least. Back then, a patient went to a local doctor, the doctor provided a service, and the patient paid a direct, transparent bill.
Simple.
Very simple. The policy debates back then were primarily just about how to provide financial assistance to the people who couldn't afford that direct bill. But the source argues that today the complexity is intentional. As the text puts it, today complexity serves margins, not care.
Wow. Complexity serves margins. And listen, this isn't just an abstract frustration for, hospital accountants. This systemic drag directly impacts the listener.
It hits their wallet directly.
Because this opacity is systematically suppressing the take-home pay of the American worker.
Yeah, explain how that works with employers.
Well, your employer calculates your total compensation as one single bucket of money, right? It includes your salary, your payroll taxes, and your health benefits. Every single year, as these opaque conglomerates extract more profit and push those insurance premiums higher and higher.
The employer has to pay more.
Yes. Your employer has to divert a larger chunk of your compensation bucket just to maintain your exact same health coverage.
So the raise you were supposed to get?
Poof. It's gone. That is money that would otherwise go straight into your paycheck. The system is quite literally acting as a systemic drag on your wages.
Okay, so if that is the comprehensive diagnosis that these vertically integrated, rent-seeking middlemen have engineered an opaque, highly financialized monopoly that suffocates patients, employers, and providers.
Right.
How does the author propose we actually dismantle it without just blowing up the whole economy?
That is where we move into the first major proposed solution in the text. It's a theoretical, legislative framework that the author calls the Healthcare Transparency and Competition Act of 2027.
Okay, so this is the Cuban-style approach.
Exactly. It is a blueprint for a radical, purely market-driven overhaul.
So it's an aggressive attempt to basically use the heavy hand of federal regulation for one specific purpose,
Right.
to force absolute transparency, thereby allowing actual free market competition to finally return to the healthcare sector.
Spot on. And the first pillar of this proposed legislation, Title I, is basically a sledgehammer. It outright prohibits vertical integration in healthcare.
Just bans it entirely.
Bans it.
Yeah.
It essentially draws a hard legal line between the different functions of the industry. If you are a massive corporate entity, you can operate a health insurance company,
Okay.
or you can operate a pharmacy benefit manager, or a retail pharmacy chain, or a hospital system.
Yeah.
But you absolutely cannot do more than one of those things at the same time.
Wow. The structural impact of that would be tectonic.
Earth-shattering for these companies.
The text outlines a 5-year divestiture period for this. So if you are a giant insurance company that previously bought up a massive retail pharmacy chain and a nationwide PBM,
Which is exactly what they've all done.
right, you have 60 months to sell them off into independent, competing entities. It completely destroys their ability to hide profit margins across different internal corporate divisions.
And to make sure it actually sticks, the legislation requires the Federal Trade Commission and the Department of Justice to aggressively review any healthcare merger over $100 million.
So no more sneaking acquisitions through.
Exactly. And it also targets anti-competitive contracting, which brings us back to those gag clauses.
Oh, the gag clauses are infuriating.
I find it genuinely astonishing that gag clauses are even a real thing, legally. But right now, pharmacists are routinely legally barred by their PBM contracts from telling a patient that a medication would actually be cheaper if the patient just paid cash instead of running it through their insurance.
Let that sink in. The pharmacist knows you could save $20 by just not using your insurance, and if they tell you, they can be sued or dropped from the network.
It's insane. So this legislation bans those clauses outright.
Which leads directly into the second pillar of the proposal, Title II, radical price transparency. This is the mechanism that replaces all that opacity.
Turn the lights on.
Exactly. It mandates the creation of a public health care pricing database. Every single healthcare provider, every hospital, every clinic, every single MRI imaging center would be legally required to publish a comprehensive, machine-readable list of their prices.
No more secret menus.
None. They have to show the cash price, the specific negotiated rate they have with every single insurer, the Medicare reimbursement rate, and the average total cost for an entire episode of care.
And it isn't just going to be, a giant unreadable spreadsheet dumped on some obscure government website that crashes every 10 minutes.
No, it has to be usable.
Right. The proposal includes building a national healthcare price exchange. Basically, it's an airline ticket model.
Like booking a flight.
Exactly. Think about it. When you want to fly from New York to Chicago, you don't call up Delta and American Airlines and ask them to, mail you a secret quote in 3 weeks.
No, you open a search engine.
You type in your route, and you instantly see every airline, the prices, the baggage fees, the layover times, and then you make a rational consumer choice.
The national exchange would operate identically for healthcare. A patient could just type in, say, knee replacement and plug in their zip code.
And instantly view the total bundled cost at 4 different local hospitals.
Right alongside their quality metrics, their infection rates, and their average wait times.
It puts the power entirely back in the hands of the patient. Along with this, the legislation tackles the PBMs directly in Titles III and V. It bans spread pricing entirely.
So the bouncer can't upcharge the drinks anymore.
Exactly. PBMs would be forced to operate as pure pass-through entities. If an employer's health plan pays $50 for a drug, the PBM must legally transmit all $50 to the pharmacy.
They can't skim anything off the top?
Right. The PBM can only charge a flat, transparent administrative fee for processing the claim. Manufacturer rebates, which the source accurately frames as basically legalized kickbacks, are totally eliminated.
Good riddance.
Seriously, any discount negotiated with a drug manufacturer must be immediately applied to the price the patient pays right at the pharmacy counter.
And we actually have a real-world proof of concept for how destructive this kind of transparency is to these incumbent monopolies.
Oh, you mean Cuban's actual company?
Right. The text points to Mark Cuban's existing venture, Cost Plus Drugs. The legislation essentially proposes taking that and making it a nationwide cost-plus pharmacy model.
How does that work exactly?
So pharmacies would disclose the exact wholesale acquisition cost of the medication. They say, this cost us $5 to buy. Then they add a flat, transparent markup. In Cuban's case, it's just 15%.
Okay, so 15% on top of the wholesale cost.
Right. And then they add a flat shipping or dispensing fee.
Mhm.
By completely bypassing the entire PBM rebate shell game, this model has consistently driven massive savings. The source notes it routinely reduces the cost of generic medications by 50 to 90%.
That is life-changing money for people on daily medications.
Absolutely, and the legislation goes even further to empower the consumer. It mandates that if a patient uses this transparency to find a cheaper medication at a cash pay pharmacy, that cash payment must legally count toward their insurance deductible and their out-of-pocket maximum.
Oh, that's huge. Because right now, the insurance companies actively penalize you for being a smart shopper.
Yes, they do.
If I find a drug for $20 in cash, but my insurance copay would have been $50, and I choose to just pay the $20 in cash, my insurer refuses to credit that $20 toward my deductible because I supposedly went outside their system.
It's a trap to force you to use their PBM.
Exactly. So the proposed legislation forces them to count every single dollar you spend on care, no matter where you found the deal.
It also gives employers a major escape hatch in Title IV. The legislation creates safe harbor protections for direct employer contracting.
This sounds big for businesses.
It is. Since employers fund the bulk of private insurance in this country, this provision allows self-insured companies to completely bypass the big insurance conglomerates and the PBMs entirely.
Just cut out the middleman entirely.
Yep. An employer could simply sign a direct, transparent contract with the local hospital system and a local physician group to provide care for their employees at a known negotiated cost.
Wow. So if an employer cuts out the 20 or 30% margin that was previously just being extracted by the middlemen, they can dramatically lower their total healthcare spend.
Absolutely. And they could use those savings to basically eliminate out-of-pocket costs for their employees entirely while still paying the actual doctors a higher rate than the insurance companies were paying them.
It's a win-win for everyone except the conglomerate.
Exactly.
Okay, but I am going to push back here.
Go for it.
Because this is the exact point where the pure free market ideology always seems to hit a brick wall in the real world.
The emergency problem.
Yes. Radical price transparency and consumer shopping, they sound absolutely phenomenal if I need a knee replacement or if I'm looking for a daily cholesterol medication.
Because you have time.
Right. I have weeks to research. I can sit at my computer, use the National Exchange, look at infection rates, and make a highly rational, calculated consumer decision.
Like buying a car.
Exactly. But healthcare is fundamentally different from buying a car or an airline ticket. What if I am in the back of an ambulance actively having a massive heart attack?
Right.
Or what if I am struck by a vehicle while crossing the street? I am unconscious. I am bleeding. I cannot pull out my smartphone, open the National Healthcare Price Exchange, and tell the paramedics, hey guys, please divert to the hospital across town because their cardiac unit is 15% cheaper.
You are in no position to negotiate.
Exactly. The free market requires a rational, deliberate consumer. Emergencies completely destroy consumer agency. So how does a pure market fix handle catastrophic, non-shoppable events?
And that is the ultimate and arguably the most valid critique of treating healthcare entirely as a commodity. The text fully acknowledges that you cannot price shop from a stretcher.
So that's a fix.
However, the proposed legislative blueprint addresses this structural flaw by building in significant federal safety nets, primarily through Title VIII, which is a concept called universal catastrophic coverage.
Okay, how does that work in practice?
It acts as an absolute ceiling on financial ruin. The proposal suggests that the federal government would step in and cover 100% of all medical costs for any individual once their spending exceeds a specific annual threshold.
Do they give a number?
The text suggests a figure like $25,000.
Okay.
Every single American citizen is automatically enrolled in this catastrophic safety net. If you have that massive heart attack or, say, require complex oncology treatments, your private insurance or your own savings cover the initial cost up to the threshold.
Up to the $25K.
Right. But once you hit $25,000, the federal public system catches you. It completely eliminates the possibility of medical bankruptcy.
Okay, that definitely solves the financial ruin aspect of an emergency for the patient. But wait, what stops a hospital from simply charging $100,000 for that emergency heart attack, knowing that the government is just going to pick up everything over $25,000?
That is where Title VI comes into play. Episode-based pricing combined with the broader market forces of transparency we just talked about.
How does that stop the price gouging?
Well, while it's true you cannot shop for an emergency, the vast majority of healthcare spending, chronic disease management, elective surgeries, diagnostic imaging, daily prescriptions, all of that is shoppable.
Right, it's like 80% of healthcare.
Exactly. If millions of consumers and direct contracting employers are ruthlessly shopping for all of those non-emergency services using the national exchange, hospitals are forced into fierce price competition.
They have to lean out their operations to compete for the everyday business.
Precisely. The rising tide of market discipline lowers the baseline operating costs for the entire hospital. A hospital cannot maintain an incredibly bloated, inefficient cost structure for their emergency room if the rest of their departments have been forced into aggressive efficiency by the transparent market.
The overhead drops everywhere.
Right. Furthermore, episode-based pricing encourages hospitals to offer a flat, bundled price for an entire suite of emergency interventions rather than itemizing thousands of individual supplies and markups like charging you $50 for an aspirin.
So the argument is basically that exposing the 80% of healthcare that is shoppable to brutal market forces naturally disciplines the pricing of the 20% that isn't shoppable.
That's the theory, yes. The proposal sets a massive macroeconomic target in Title X to utilize this transparency to drive total U.S. healthcare spending from roughly 18% of GDP down to somewhere between 12 and 14% over 15 years.
Which is trillions of dollars in savings.
Massive savings. It is a comprehensive vision for a heavily regulated, hyper-transparent capitalist market. Break the monopolies, force prices into the light, eliminate the rent-seeking middlemen, and rely on competition to drive down costs while maintaining a catastrophic public safety net.
I mean, it's an incredibly robust plan. You could easily build a massive political movement just around those ideas. But the source material does something truly unexpected here. It takes a massive pivot.
This is where it gets wild.
Right. We are moving into the most fascinating argument of the entire text, the 10-year bridge.
Yeah. The author suggests that Mark Cuban's hyper-capitalist, market-driven reforms might actually be the absolutely required prerequisite to successfully implementing a progressive, government-run, single-payer system.
I remember reading that part and literally having to stop and reread it.
It seems like a paradox.
It does. The capitalist transparency fix is a necessary first step for the socialist single-payer destination. I mean, how does it even work?
Well, the text grounds this in historical policy failures. It states very clearly that designing a functional single-payer system on a whiteboard is not actually the difficult part.
We have blueprints.
We do. Almost every other developed nation on Earth has demonstrated some functional variation of national health insurance. We know what the destination looks like. Where single-payer proposals in the United States constantly fail, both politically and economically, is the transition.
The messy middle.
Exactly.
Because you're trying to fundamentally rewire a system that consumes over $4 trillion annually. It employs millions of Americans in insurance, billing, claims adjudication, and administration. And for the vast majority of the working-age population, their access to a doctor is inextricably tied to their employer.
You cannot simply flip a switch on a Tuesday and declare the entire private insurance industry illegal.
It would be chaos. It makes me think of trying to do a massive gut renovation remodel of a house while your family is still actively living inside of it.
Oh, that's a great analogy.
Right. You can't just take a sledgehammer and knock out all the load-bearing walls on the first day.
The roof would collapse on the occupants.
Exactly. You have to build temporary supports. You have to carefully shift the weight of the structure. You renovate one room at a time, moving the family around, ensuring they still have a place to sleep and a functional kitchen, while the massive structural changes are happening in the background.
And that is exactly what this 10-year phase glide path represents. It ensures the system doesn't collapse on the patients or the providers while the plumbing is being replaced.
So let's examine the architecture of those temporary supports. The source outlines a 10-year transition pathway, divided into 5 distinct phases.
Phase 1 covers the first 2 years. And the core objective of Phase 1 is implementing the exact Cuban-style market reforms we just discussed. Full price transparency, the prohibition of vertical integration, PBM reform, and the national price exchange.
But wait, why is radical market transparency the necessary first step for a single-payer system?
This is the economic brilliance of the author's sequence. Currently, the prices in the U.S. healthcare system are completely fictitious.
They're made up.
Totally made up. They are artificially inflated by the opaque conglomerates, the spread pricing, the uncollected deductibles, and the massive administrative overhead. If the federal government attempted to implement a single-payer system tomorrow, they would have no baseline to negotiate from.
Oh, they would just be blindly adopting and subsidizing those massively bloated, hyperinflated middleman prices.
Right. You essentially be locking in the corruption and funding it with taxpayer money forever.
That makes total sense. So phase one utilizes the ruthless efficiency of market transparency to aggressively wring that artificial inflation out of the system first.
Exactly. By forcing hospitals and pharmacies to compete openly on cash prices, you strip away the administrative bloat and discover the true underlying cost of delivering care. You must clean the pipes and establish a rational baseline price before you ask the government to finance that care for 330 million people.
So you use capitalism to clean up the mess, and once the actual cost of a knee replacement is known, you move to phase two.
Right. Phase 2 covers years 2 through 4 of the transition. The text calls this the Medicare buy-in.
What happens in phase two?
In this phase, the government opens up the existing Medicare program to anyone. Any individual, regardless of their age, or any employer in any state, can voluntarily purchase Medicare coverage. Medicare essentially becomes a robust public option competing directly in the newly transparent marketplace.
Competing against the private plans.
Yeah.
But there is no mandate, right? It is entirely voluntary.
Entirely voluntary. Employers can review their options, they can look at the fully transparent private insurance plans on the exchange, or they can look at the premiums for the Medicare buy-in.
And what's the expectation there?
Because Medicare operates with remarkably low administrative overhead and doesn't need to generate quarterly shareholder profits, the text posits that millions of individuals and thousands of businesses will voluntarily migrate their employees to the public system simply because it offers better value.
So it creates organic, market-driven momentum toward the public pool without any political coercion.
Exactly. People just choose it because it's cheaper.
Which leads into phase three, covering years 4 through 6.
Yeah.
This is where the structural weight really begins to shift, right?
Right. This is where the government starts systematically lowering the automatic eligibility age for Medicare.
So dropping it from 65.
Yes, the age drops in increments, from the current 65 down to 60, then 55, and then 50.
Over 2 years.
Right. By doing this gradually over 2 years, millions of older, generally more expensive patients are steadily shifted out of the private insurance risk pools and absorbed into the public system.
Which gives the private insurers time to adjust.
Exactly. This gradual off-ramping allows the massive private insurance industry to manage the disruption to their business models slowly rather than facing an overnight cliff where they just go bankrupt.
And simultaneously, during phase three, the massive state-by-state patchwork system of Medicaid is gradually merged into the federal Medicare apparatus.
Standardizing the bureaucracy, you're unifying the public safety nets.
Okay, so by the time we reach phase four, which covers years 6 through 8, the tipping point has been crossed.
Definitely. The vast majority of the population is already interacting with or entirely covered by the expanding public system. Phase 4 introduces universal public coverage.
Meaning everyone gets it.
Every American citizen automatically receives core hospital, physician, and prescription coverage through the unified public pool. Private insurance is legally shifted into a supplemental role.
Like maybe covering a private hospital room or elective cosmetic surgery.
Right.
The temporary supports are basically being removed because the new foundation is finally solid.
And finally, we hit phase 5, years 8 through 10, full single payer. The private insurance industry ceases offering primary coverage that duplicates the core services provided by the public system. The transition is complete.
It's just breathtaking in its scope. Over the span of a single decade, you have moved an entire nation from an opaque, vertically integrated, profit-driven cartel through a period of radical market discovery and safely into a unified public system.
The source argues so effectively that market reform and single payer are not mutually exclusive political enemies. They're actually sequential tools required to build a rational system.
Okay. We have survived the 10-year remodel. The dust has finally settled. We are standing in the new house.
Let's look around.
Right. What does the destination actually look like? The text outlines the final statutory framework under the title, the American Health Security Act.
And the foundational philosophy of this act is a total paradigm shift. It officially establishes healthcare as a guaranteed universal human right for every American citizen.
Right, not a commodity.
Exactly. Aiming to simultaneously drive down national expenditures, completely eradicate medical bankruptcy, and vastly simplify the administrative burden on providers.
So the machinery starts with Title I, universal coverage. Enrollment is automatic upon birth or upon establishing legal residency. There are no open enrollment periods to remember, no complex applications to fill out online, and no eligibility tests to pass.
You exist, therefore you have health care.
But the most transformative part of this for the average patient is the complete elimination of financial barriers at the point of service.
The text is explicitly clear here. The American Health Security Act abolishes monthly premiums, it abolishes annual deductibles, and it abolishes all those complex coinsurance structures.
The 80-20 splits.
All gone. And perhaps most importantly, it entirely eliminates the concept of provider networks. The terms in-network and out-of-network simply cease to exist.
That alone is massive.
A patient can see any licensed physician or check into any public or nonprofit hospital in the entire country, and their care is automatically covered. The text notes that nominal, strictly regulated copays might remain for certain non-essential or highly discretionary services, basically just to gently discourage overutilization. But the crushing financial friction of core medical care is gone.
But a system of that magnitude requires an astonishing amount of capital. I mean, how is this unified system actually funded? Where does the money come from?
Title II creates a single national health fund managed by a new entity called the American Health Trust. Private insurance companies are entirely removed from the business of paying for core medical services.
So how does the trust get its money?
The funding mechanism is a synthesis of several massive revenue streams. First, it implements a shared employer-employee payroll tax.
Similar to Social Security.
Right. Second, it institutes a progressive income tax surcharge, ensuring that higher earners contribute a larger share of the burden. Third, it applies a dedicated tax on capital gains and unearned income.
Okay, so a mix of new taxes. But it's not all new taxes, is it?
No, and this is crucial to understand. The final and arguably largest funding stream is the massive redirection of all existing federal and state healthcare expenditures.
All the money we already spend.
Yes. Every single dollar currently spent on Medicare, Medicaid, the complex web of Affordable Care Act subsidies, the Children's Health Insurance Program, and the Veterans Affairs healthcare system. All of it is aggregated and redirected into the single unified national pool.
Okay, I want to spend the significant time on the next part of this act, Title III, because it fundamentally alters the financial behavior of the entire medical profession. It introduces global hospital budgets.
This is a radical departure from how American medicine operates today. Currently, hospitals operate on a fee-for-service model.
Explain how that works.
They bill for every individual action, every scalpel used, every minute of operating room time, every single aspirin dispensed is coded, marked up, and billed separately to an insurance company.
Which incentivizes volume over value. If a hospital wants to make more money, they simply need to perform more procedures, regardless of whether those procedures actually make the patient healthier.
Global budgeting destroys that incentive entirely. Under this act, hospitals no longer bill per procedure. Instead, they receive an annual, comprehensive operating budget directly from the American Health Trust.
A lump sum for the year.
Exactly. This budget is calculated based on the historical volume of the hospital, the demographics and health risks of the surrounding community, and their projected capital needs for new equipment or expansions.
This operates exactly like a municipal fire department.
Right.
I mean, when a fire department shows up to extinguish a blaze at your house,
Yeah.
they don't, hand you an itemized invoice when the smoke clears.
Could you imagine they don't charge you a per-gallon fee for the water they sprayed?
Right. Or an hourly rate for the firefighters, or a surcharge for using the ladder truck. It would be completely absurd.
Totally absurd.
A fire department is funded by a global municipal budget. We pay them to exist. We pay them to maintain their equipment, to conduct training, and to maintain a state of constant readiness so that when the community experiences an emergency, the resources are instantly available.
You're paying for readiness.
Yes. The philosophy behind global hospital budgets asks the very obvious question. Why don't we treat our critical healthcare infrastructure the exact same way?
And by prioritizing readiness and community health over transactional volume, you eliminate the financial incentive for a hospital to upcode diagnoses or perform unnecessary, highly profitable, elective surgeries just to keep the lights on.
What about private practice doctors?
Physicians are given the option to remain on a strictly regulated fee-for-service schedule if they choose, but they are heavily incentivized to transition to salaried positions or group practice contracts.
And the downstream effect of eliminating per-procedure billing is the complete eradication of what hospitals call their revenue cycle departments.
The administrative savings here are just staggering. The The text points out in Title V that currently, roughly 25 to 30% of all U.S. healthcare expenditures are consumed by administrative friction.
30%. That's hundreds of billions of
You're
dollars.
wasted every single year. Hospitals currently employ literal armies of medical coders, billing specialists, and collections agents whose entire professional existence is dedicated to arguing with the opposing armies of claims adjusters and denial algorithms employed by the insurance companies.
It's an invisible war of paperwork. And the crazy part is, the patient's premium dollars are funding both sides of the battlefield.
Exactly. The Act mandates a single, unified national claims standard and integrated electronic health records that are fully owned and accessible by the patient. By moving to global budgets and a single payer, you instantly dismantle that invisible war. The stated objective is to drive that administrative bloat from 30% down to below 10% of total spending.
Okay, but this forces us to confront a brutal economic reality.
The job.
The jobs. If you eliminate the need for private insurance claims processing, if you dismantle those massive hospital revenue cycle departments, and if you streamline the billing administration across the entire country, you are going to displace hundreds of thousands, if not millions, of American workers.
It's a massive shock to the labor market.
You are wiping out an entire sector of the white-collar economy.
You cannot build a utopia on the sudden financial ruin of millions of citizens whose only crime was working an administrative job in the healthcare sector.
Right.
The source acknowledges this profound disruption and details a comprehensive workforce transition plan.
How do you even absorb that kind of shock?
The Act establishes a healthcare workforce adjustment fund. This is a massive, multi-year federal program designed specifically to support those displaced workers. It guarantees up to 2 years of their current salary while they transition to new employment.
That's a solid safety net.
It fully funds aggressive retraining programs, tuition assistance for those who want to transition into actual clinical care roles like nursing or phlebotomy, and provides robust job placement services. For older workers nearing the end of their careers, the fund provides subsidized early retirement packages.
Okay. It also includes a hospital transition fund. Why is that necessary if hospitals are already getting global budgets?
Because the current financial architecture of many hospitals is incredibly fragile and heavily reliant on complex cross-subsidies. Right now, a hospital might lose money treating uninsured patients, and they might barely break even treating Medicaid patients, so they survive by massively overcharging patients with private employer-sponsored insurance.
Oh, I see.
So if you suddenly equalize the payments across the board through a single payer, some hospitals, particularly inner-city safety net hospitals or rural facilities, might struggle to adapt to their new global budgets immediately. The 5-year transition fund acts as a financial shock absorber to ensure no critical access hospital is forced to close its doors during the implementation phase.
So if we look at the destination on paper, it sounds like an absolute triumph of public policy. I mean, for the patients. You get a single healthcare card, absolute freedom to choose your doctor, no deductibles, and the total eradication of medical debt.
Incredible.
For the physicians.
Yeah.
You deal with one unified payer, your administrative paperwork is slashed, and you finally spend your time practicing medicine instead of arguing with insurance algorithms.
Which is what they went to school for.
Exactly. And for American businesses, you are completely freed from the burdensome, expensive role of acting as a healthcare broker for your employees, which drastically lowers your labor costs.
It sounds perfect.
It does.
But flawless utopias do not exist in the realm of macroeconomic public policy. Every system, no matter how elegantly designed, is fundamentally an exercise in navigating trade-offs.
There's always a cost.
Always. And the author of the text dedicates a massive, rigorous section to evaluating the brutal realities and the highly valid criticisms of single-payer healthcare. We must examine these with total objectivity.
This is where the theoretical meets the practical. The source breaks down 9 specific, formidable criticisms of transitioning to a single-payer system. We need to go through these methodically. Let's start with the loudest and most immediate concern. Criticism number 1. Taxes would skyrocket.
The text is unapologetically blunt here. This criticism is entirely factually correct. Implementing a single-payer system requires a monumental increase in federal taxation.
There's no hiding that.
None, because the government is effectively absorbing the massive financial burden currently borne by employers and private households.
But the text argues that looking only at the tax line item is mathematically incomplete, right?
Yes. The debate really hinges on the concept of total healthcare spending versus public healthcare spending. Right now, the average American worker pays a massive hidden tax for their healthcare.
It just doesn't say tax on the pay stub.
Right. It comes in the form of reduced wages because their employer is paying exorbitant premiums. And it comes in the highly visible form of deductibles, copays, and out-of-pocket expenses. Under the American Health Security Act, your public tax burden definitely increases significantly, but your private household spending on premiums and deductibles immediately drops to absolute zero.
So the core question is whether the administrative efficiency and the massive negotiating power of a single-payer system drive the overall systemic cost down far enough that the average citizen experiences a net financial gain, despite paying higher taxes.
Exactly. You might pay $5,000 more in taxes, but save $10,000 in premiums. International data from peer nations strongly suggests it can work, but achieving that efficiency in the unique, highly polarized political environment of the United States remains a profound execution risk. It is a massive, unprecedented shift in how wealth moves through the economy.
Let's move to criticism number 2, which is arguably the most terrifying for patients: wait times. Whenever single-payer is brought up, critics point to systems like Canada or the United Kingdom, citing stories of patients waiting 6, 8, or 10 months for a hip replacement or a specialist consultation.
And once again, the source validates the concern. It doesn't shy away from it. In heavily centralized, publicly funded systems, the government controls costs by capping the supply of medical resources.
Because the budget is fixed.
Right. When care is free at the point of service, demand naturally rises. When demand outstrips a capped supply, you get queues. Wait times for elective, non-life-saving, or non-emergency procedures are a very real, highly documented friction point in single-payer models.
But the text forces us to look in the mirror regarding our own system. We point fingers at Canada, but the text argues the United States already has a massive crisis of wait times.
They're just invisible.
Invisible wait times. Explain that.
We ration care differently. We ration care through financial barriers. If a patient in the U.S. knows they need a knee replacement, but their deductible is $6,000, they might wait 2 years to save up the money before scheduling the surgery.
That patient is waiting.
Exactly. They are on a government list, but they are in a state of delayed care. Or consider the physician who prescribes a necessary medication, but the patient has to wait 3 weeks while the doctor's office fights a PBM for a prior authorization.
Also waiting.
The text argues that wait times are not an inherent, unavoidable feature of single-payer financing. They are a symptom of inadequate medical capacity. If the U.S. heavily invested in expanding medical schools, nursing programs, and hospital infrastructure, which is proposed in the broader legislation, it could mitigate the queuing. But the tension between unlimited access and limited capacity is an unavoidable reality of physics.
You can't cheat physics. Which leads directly into criticism number 3. Government inefficiency. The classic, highly resonant argument here is that a government that struggles to run the Department of Motor Vehicles efficiently has absolutely no business managing something as intricate, personal, and life or death as the healthcare sector.
The fear of the monolithic bureaucracy.
It's a huge fear.
And it is a legitimate risk. Government agencies can absolutely become rigid, slow to adapt, and completely insulated from the consequences of poor performance. However, the text demands that we compare that risk against the reality of the current private market.
The status quo.
Right. We do not currently have a sleek, efficient, frictionless healthcare system. We have hundreds of competing, contradictory private bureaucracies.
A doctor doesn't just deal with insurance as a monolith. They deal with Blue Cross, United Healthcare, Aetna, Cigna, Medicare, and Medicaid.
And each of those entities has a completely different set of rules, a different formulary, a different prior authorization process, and a different proprietary software portal that crashes.
It's madness.
So the author poses a fundamental question. Is the theoretical risk of one large, unified, standardized public bureaucracy ultimately more dangerous or less efficient than the current reality of hundreds of private bureaucracies whose primary fiduciary due to their shareholders is to find ways to deny paying for care?
Right. The government might be slow, but they aren't actively incentivized to deny your claim to boost their stock price.
Exactly. A single payer means a single set of rules. The friction decreases even if the government administrator is moving slowly.
Let's talk about the future of medicine. Criticism number 4. Innovation collapses. The argument here is that the American system, with its massive profit motives and incredibly high prices, is essentially the engine that drives global pharmaceutical and medical device breakthroughs. If the U.S. government subtly implements aggressive national price negotiations and caps profits, the venture capital funding for developing the next miracle cure for Alzheimer's or cancer will completely dry up.
There is undeniable truth to the premise. The high prices paid by American consumers effectively subsidize the research and development pipeline for the entire globe.
We pay more, so the rest of the world can pay less.
Essentially, yes. European nations negotiate massive discounts on drugs because they know the pharmaceutical company will recoup its R&D costs in the highly lucrative U.S. market. If a single-payer system aggressively slashes the profit margins, private capital will inevitably flow toward more lucrative sectors, like technology or artificial intelligence.
But the text points out that the narrative of the heroic, self-funded pharmaceutical company is vastly overstated.
Yes. The foundational, high-risk, early-stage research for almost every major medical breakthrough in the last 50 years has been heavily subsidized or directly funded by the American taxpayer.
Through entities like the National Institutes of Health or the NIH.
Exactly. The government funds the risky discovery phase, and then private companies often step in later to patent, commercialize, and market the final product at extortionate margins.
So the policy challenge isn't abandoning innovation entirely. The challenge is finding the correct equilibrium. How do we preserve a strong enough financial incentive to reward a company for successfully bringing a cure to market without allowing that company to hold society hostage with $1 million price tag?
You don't have to eliminate profitability entirely, but a single-payer system gives society the leverage to negotiate exactly how much profit it is actually willing to tolerate.
Moving on to criticism number 5, which deals directly with the providers, doctor pay drops.
This one seems inevitable.
Right. If the government is the only buyer of healthcare, they dictate the prices.
And historically, public systems reimburse at lower rates than private insurance. For primary care physicians, a single-payer system might actually increase their take-home pay by valuing preventative care more highly. But for highly specialized fields, orthopedic surgeons, cardiologists, neurosurgeons who earn dramatically more in the United States than their counterparts in any other developed nation, a single-payer system would almost certainly exert downward pressure on their gross reimbursement rates.
But we have to factor in the administrative savings we talked about earlier.
Exactly. This is the crucial offset. If a specialist's gross revenue drops by 15%, but their massive administrative overhead, the cost of employing multiple billing specialists and fighting insurance denials drops by 20%.
Their actual net take-home pay might remain completely stable or even increase.
Right. And furthermore, their daily professional frustration plummets. But the text concedes that managing provider compensation to ensure the medical field continues to attract the highest tier of talent remains a really delicate balancing act for any public system.
Let's tackle criticism number 6, because I think this is the one that triggers the deepest emotional response in American voters, the loss of choice. Critics argue that a government system inherently strips away your freedom to choose your health care.
Yeah, freedom argument.
Yes, I really want to examine this based on how the source breaks it down, because I think we suffer from a deep cultural delusion regarding choice. Well, as Americans, we revere the concept of the free market. We love walking down the cereal aisle at the grocery store and seeing 50 brightly colored boxes.
It feels like infinite freedom.
It does. But the reality is that 45 of those boxes are made by the exact same 3 massive parent companies, and the contents are mostly just variations of corn and sugar. We love the illusion of choice.
That analogy translates perfectly to the current health insurance market.
It really does. Think about it. During open enrollment every November, we log into a portal, and we agonize over having a choice between 15 different private insurance plans. A gold plan, a silver plan, a high deductible plan from this conglomerate or that conglomerate. We are deeply emotionally attached to the freedom to choose our insurance plan. But the dark irony is that we actually hate all of those plans.
They're all incredibly complex.
They all feature high deductibles, and they all try to deny coverage. And worse, our obsession with choosing an insurance company actually violently restricts our freedom to choose a doctor.
Because of the networks.
Because once you pick a plan, you are trapped inside their narrow proprietary network. If the best oncologist in your state happens to be out of network for your specific silver plan, you cannot see them without facing total financial ruin.
The source captures this dynamic brilliantly. The criticism that you lose choice under single payer is technically accurate, but practically misleading. Under the American Health Security Act, you absolutely lose the freedom to choose between dozens of competing private insurance administrators. The middleman is eliminated.
But in exchange for surrendering that specific administrative choice.
You gain the unlimited, absolute freedom to choose any doctor, any specialist, and any hospital in the entire country. Because the very concept of a restricted provider network ceases to exist. The debate isn't about losing choice. The debate is simply about which type of choice the administrator or the physician you value more highly.
Criticism number 7, transition disruption.
The author explicitly labels this as the most formidable and valid criticism of all.
The scariest one.
Yes. We covered the mechanics of this during the bridge discussion. Attempting to rapidly disassemble and rebuild a sector that represents nearly 1/5 of the entire United States economy is a terrifying proposition fraught with systemic risk. A sudden shift would cause immense economic chaos, vast unemployment in the administrative sectors, and widespread confusion among patients and providers.
Which is exactly why the source dedicated an entire section to the 10-year, 5-phase glide path. The destination of universal coverage isn't the primary risk. Surviving the turbulence of the journey without crashing the economy is the true test of the policy.
Criticism number 8 looks at human behavior. Demand explodes. The argument is that if healthcare is entirely free at the point of service, the system will be immediately overwhelmed. People will rush to the doctor for every minor sniffle, every phantom ache, and every trivial concern.
The sheer volume of frivolous utilization will bankrupt the system. Moral hazard is the economic term, right?
Yes. If you don't bear any of the cost, you consume more of the resource. And utilization would absolutely increase, particularly in the initial years. Millions of citizens who currently avoid care due to cost would finally seek treatment for lingering issues.
The strain on physical capacity would be intense.
It would. But the text provides a crucial, long-term economic counterweight to this argument.
Preventative maintenance.
Exactly. When patients have free, frictionless access to primary care, they go to the doctor when they have a minor, persistent cough. The doctor diagnoses early-stage asthma and prescribes a cheap inhaler. Under the current system, that same patient avoids the doctor because of a high deductible, the asthma goes untreated, and 3 years later they suffer a catastrophic respiratory failure.
And they spend a week in an intensive care unit costing the system hundreds of thousands of dollars.
Exactly. Removing the financial barrier shifts the nation's healthcare spending away from reactive, incredibly expensive emergency interventions and toward proactive, vastly cheaper disease management.
Finally, criticism number 9, the scale and diversity of the United States. Critics frequently argue that while a single-payer system might function beautifully in a small, homogeneous nation like Norway or Denmark,
It is completely unworkable in a massive, sprawling, highly diverse, politically polarized country of 330 million people spread across a continent.
I hear that one all the time.
Operating anything at a continental scale introduces immense logistical complexity. But the source calmly deflates the idea that the U.S. government is inherently incapable of massive administration.
Because we already do it.
We do. The federal government already successfully operates some of the largest social insurance programs in human history.
Right. Social Security and the current iteration of Medicare.
Medicare already provides complex medical coverage for over 60 million elderly and disabled Americans. That risk pool alone is larger than the entire population of many European nations. The administrative machinery, the data infrastructure, and the logistical capability to handle scale already exist within the federal apparatus.
So the hurdle isn't mathematical scale. What is it?
The author argues that the true hurdle is political stability. The real risk is whether our highly polarized, constantly shifting political institutions actually possess the discipline and the stability to sustain, fund, and manage a unified national healthcare system over the span of decades without intentionally sabotaging it for partisan gain.
Wow. We have really walked through the fire today. We started by examining the illness of opacity, the vertically integrated conglomerates, and the PBM bouncers extracting wealth in the dark. We explored the radical Cuban-style market fix that uses the hammer of transparency to wring inflation out of the system.
And then we crossed the 10-year, 5-phase bridge.
Right, using capitalist reforms to pave the way for a public system. We analyzed the grand destination of the American Health Security Act, the global hospital budgets, and the massive workforce transitions. And finally, we just stared down the 9 brutal, highly valid criticisms of a single-payer reality.
And what emerges from this incredibly rigorous journey is a highly clarified picture of reality. The author concludes the blog post by reminding the reader that the debate over healthcare is not a grand, romantic, cinematic contest between the virtues of compassion and the evils of capitalism.
It's not good versus evil.
Nor is it a battle between universal human rights and pure economic freedom.
It is entirely a mathematical, deeply practical calculation.
It is. Perfection simply does not exist in healthcare policy. Utopias are a myth. Every possible system has profound flaws. A single-payer system promises the immense relief of universal access, simplified administration, and massive national bargaining power. But it requires the heavy burden of higher taxes, relies on an entrenched government bureaucracy, and constantly battles potential capacity constraints and wait times.
While the current, highly financialized private system promises the theoretical engine of rapid innovation and the illusion of consumer choice.
But it delivers a reality of crushing administrative bloat, heavily restricted access to actual doctors, delayed care, and life-ruining financial barriers for everyday citizens. The policy challenge facing the country is not about finding a flawless system. It is simply about choosing which set of imperfections we, as a society, find most tolerable.
That is an incredibly clarifying way to view the debate. We have unpacked an astonishing amount of material today from this brack-face analysis. As we wrap up this deep dive into the labyrinth, I want to leave you, the listener, with one final, provocative thought to mull over.
Something to think about.
Right. We started this journey by talking about that restaurant bill, about the profound comfort of knowing exactly what things cost and having the rational freedom to choose how you spend your money. Think about your own medical history. Think about the hours you spent on the phone listening to hold music, trying to argue with an insurance representative about a denied claim.
We've all been there.
Think about the anxiety of sweating over a deductible resetting in January, or the times you actively delayed seeking care because you just weren't sure what the final mysterious bill would be.
It's exhausting.
So if you had the power right now to press a button and permanently lock in the future of the system, would you rather guarantee your absolute freedom to choose among dozens of competing private insurance companies in a fiercely competitive free market? Or would you trade that specific freedom away forever to guarantee the absolute freedom to see any doctor in any hospital in the country without ever hearing the terrifying words "out of network" again? Thanks for joining us on this deep dive.